Yes, I consent to being recorded.
That's good. I'm just going to say how funny it is that when we start out, we were dressing in shirts and dressing nice, and now it's Sunday afternoon. We're in lockdown,
Yeah.
and we really stepped it down a notch. So hi everyone, and welcome to ABCs of Anaesthesia, and this is part 4 of an interview tips series, and this will go out as a podcast and YouTube as well. So in this episode, we're going to go through some other factors or other situations that might come up in the interview, and this is like professional issues, the non-clinical stuff, ethical questions. And so specifically, what we're going to cover is clinical governance, audits, the national standards, and then a couple of other things in terms of, ethical questions, the impaired colleague, and other questions that, might trip you up in an interview. So yeah, my name is Lahiru, and I've got here Kaz, who's a resident interview expert. And you've just been through so many, much more recently than I have, Kaz. So that's why I put that out there.
It's taken up a lot of my life for the last decade or so.
That's right. Hey, every year you're preparing for interviews, preparing for a month or two, and that's just what happens.
That's yeah.
So what do you reckon, Kaz? Let's talk about clinical governance. Now, this is obviously far more of a consultant interview question, but I thought it'd be good to talk about it. So, what's this fancy word? What is clinical governance?
So I guess the formal definition of clinical governance is that it's a set of relationships or responsibilities that are established by a health service or hospital between its state or territory department of health, the governing bodies, as well as the executive, the workforce, the patients, and the consumers, and also other stakeholders to ensure good clinical outcomes.
That's a fantastic definition.
It's a bit of a wordy definition. And I think, if you can recreate that in an interview, that's phenomenal, but I don't really think that's expected. The version of this that I often used was, clinical governance is a set of relationships and responsibilities that are established to ensure optimal patient care against the best available evidence. And everything you have within that structure is to allow that to happen. And that covers it relatively well.
That sounds good. And I noticed that this really is about, so it's about ensuring good clinical outcomes, and it's just a set of responsibilities and relationships between the health body, that's your state governing body, and all the stakeholders, and you can just really name everyone: executives, workforce, patients, consumers, and other stakeholders. So a bit of a mouthful, but if you just have a subtle understanding or very brief understanding of that, I think that will impress in the situation that you get that as a question.
Yeah.
So the next question, there's probably not much more we need to really chat about that.
Well, I guess how would you answer a question about this? So if someone says, what is clinical governance? Would you rattle off the 7 pillars, or would you, how would you use these concepts to answer a question?
Oh, that's a good question. So if they literally just asked clinical governance, I'd just make sure that I had a reasonable understanding of that definition.
Yeah.
And then I guess you could go on to those national standards. I think that's what you're mentioning.
Yeah.
So just to go through those national standards. So these are the national standards which have, I think everyone should know them, because a lot of what we do in the hospital in terms of auditing and compliance and training and education and research is about these standards. So, standard 1 to 10. So governance for safety and quality in health service organizations. Number 2 is partnering with consumers. 3 is preventing and controlling healthcare associated infections. 4 is medication safety. 5 is patient identification and procedure matching. 6 is clinical handover. 7, blood and blood products. 8, preventing and managing pressure injuries. 9 is recognizing and responding to clinical deterioration in the acute health care. And 10 is preventing falls and harm from falls. So you'll notice that a lot of these things you'll be thinking, if you didn't know about the national standards, you'll now realize that a lot of the things we do and a lot of the audits that occur in terms of, hand washing or medication safety, having alerts constantly out there on your EMR, as well as at the meetings that we go to. There's a lot of medication safety stuff, like, the pinch drugs being the dangerous drugs, and then a whole bunch of stuff, especially perioperatively, around patient identification, ISBA around clinical handover, a lot of blood product training. So you can just see how much this has infiltrated into the systems that you might work in, and just having a rough idea of a few of these is probably a good idea. What do you think, Hans?
Yeah, exactly. And I think, quite interestingly, the national standards are kind of the Australian National Health Association's adaptation of the kind of the classical clinical governance pillars, which you can Google and look up anywhere. and they're very similar, and there's a lot of crossover. But I think the national standards are actually how we accredit hospitals and how we assess the quality of the care we're giving, and it's how a lot of the initiatives within hospitals are established as well. So I think, like Larry said, you don't have to necessarily know everything. It's if you're going for the college, if you have a bit of time, memorize it. It's not terribly hard. It can be helpful, but I think it's then about thinking of how is it applied. So I would just pick 3 that you're comfortable with, and then think about how you could then apply it to improve patient care, and how even you as an individual have applied them. So, medication safety is probably super relevant for anesthesia, clinical handover super relevant for anesthesia, patient identification, and procedure matching. Those 3 are huge things that we think about and do every single day, and they're very easy things to talk about in relation to anesthesia. The other version of this question is, how do you practice clinical governance? And really, all these different standards can come down into 3 main pillars, which is audit, or the audit cycle, research, and teaching and education.
I think you've summarized that really well. So if someone had no idea of clinical governance, so that's the overarching umbrella. I really love that you've got this framework of how to make it practical, and I'm really impressed with that. That's really great. So the fact that most of us can kind of talk about audits, research, and education as the pillars of that. No, I really like that, Kaz.
Exactly. So having those 3, I think, is enough. That's all I said for my interview when I got asked this. And I think that's just a good approach to do it. So yeah.
Interestingly, I recently, we'll talk more about this, my personal experience of being on one of our interview panels, because the interview in many situations will be the deciding factor of whether you get the job or not. And so if you haven't thought about these things, I think it's really good. Even if you don't get asked, it'll give you confidence and structure your thoughts in a way that I think consultants and the people interviewing you really understand, because that's something that they live and breathe every day. So just to move on then, this is probably a far more relevant question. Kaz, tell us about the audit cycle. There's a lot of us trainees will be doing audits constantly as part of our role in various rotations. So yeah, what is the audit cycle?
Yeah. So look, the audit cycle is essentially the process by which we determine a standard to assess our practice against. And then the audit cycle is the process by which we do that. So the steps are, you identify an audit topic. So when I was a resident, I did a audit on perioperative normothermia. So there was a standard by both the NICE guidelines as well as ANSCA on reducing perioperative hypothermia to reduce the associated complications. And then you set the standard. So the standard's already been established by both ANSCA and a bigger international body like NICE. And
so you're talking about the NICE guidelines, NICE?
NICE. I was just trying to be fancy in French.
Fancy, sure.
Yeah. Yeah, the NICE guidelines. What does it stand for, Lai? Do you remember off the top of your head?
You know what? I don't actually. Why don't I quickly look that up? Because that would probably, because I refer to these guidelines all the time. All the time. I'm a big fan of them.
Yeah. So the NICE guidelines, which stand for the National Institute for Health and Care Excellence. So that was the set standard, and then you collect data. So this is what we generally say as the audit that we are doing. So you collect data that reflects your practice. So the process of how I did this was, we got a number of consultants to record perioperative temperatures of patients preoperatively, intraoperatively, and postoperatively. And then you analyze the data and you assess whether the standard was met. And then the final step of the audit cycle, which I think often gets missed, is you actually implement change based on that study.
Fantastic. So just to reiterate then, so you identify the audit topic, set the standard, it may already be set, collect the data, analyze the data, and then implement change. Now, hopefully people can remember that, but I believe in silly mnemonics. And so if you just remember ISCAI, I feel like that's something that you could potentially hang on to and hopefully remember during this process. But a lot of it's logical as well. Setting the standard, collecting data, analyzing it, implementing change. It really is the scientific method, just made a bit fancy, and chuck the audit word inside it and put a few arrows to make it a circle. Amazing.
And I guess if someone's answering this question, would you care if they missed one? Like, would you care if they missed No, exactly. It doesn't matter, right?
I really respect a rough idea of something, because I don't rate memory that much, though I think memory does give you confidence. I believe in structures and frameworks, because a lot of knowledge and memory can hang on to that, and we'll definitely go into that stuff in some of our later, especially when we go through clinical scenarios. So tell us about the college-specific things. So there's a few things that have come out more recently. I think a statement on cultural sensitivity and gender equity, as well as Indigenous health. What do you reckon? Those are things to look into detail or just be aware of?
Um, Somewhere in between, really. I think if you're completely ignorant of them, it makes it a bit challenging. In saying that, if you're a reasonable person whose views are relatively in line with what the college's views are, you can probably get by with saying what you think they would want to say. And people have definitely done this in interviews, and it's fine.
What are you saying? That if I don't agree with it, I should just say I do? Is that?
Oh, that's a very challenging
Look,
line of questioning.
well, I think what they're stating in these statements is stuff that it's just really compassionate stuff. So I'd be quite shocked if people disagreed with kind of the stuff that's saying, gender equity, equality of opportunity for people, trying to protect the most vulnerable people in our community. I feel like these are just really nice things that everyone should be thinking about.
Exactly. And if you actually read some of these documents, there's a fair bit of time given to, I think, appreciation of opposite views. And I think that's something our college does really well. They kind of go, look, we know not all members might reflect these, but this is what the majority reflect, and we think this is in line with the ethos of the college, and therefore we're making this statement. And I think they did the same thing when they made a statement on that family that's currently held in detention and aren't being allowed to settle. So I think the college does that really well, and kind of they aren't making it seem like they reflect everyone, but they reflect the majority. So I think that's what you should say, because that they are still your governing body. So I guess have a general idea of what the policy is. If you have a chance to look through them, it's super helpful. It doesn't take very long. So I looked through the last few bulletins, saw that there were a number of topics that were kind of in vogue, or kind of was the priority of the current president, or the previous president at the time. And then you just kind of know a few pillars, know what their approach is, and know what they want to do, and that's really it. I think have 3 points. I'm a big fan of threes. I'm a simple man, so just have three things that they want to achieve, and 3 ways that they go about achieving it. And I think that's a good way to prepare for this sort of question.
Yeah, sounds good. So that was, we talked a bit about clinical governance, and then things that move out of that: audit cycles, research education, the national standards. So, hopefully now that you've heard this, hopefully you do get a question, because I feel like a lot of people won't be able to answer this in an eloquent way.
So I guess another question that's very related to the college, which does get asked quite often, is what you know about the college, or what you know about the training program. And I think this really helps differentiate a prepared candidate. And essentially, there's no right answer. And you don't need to really sell yourself in this question. You just want to show them that you care enough about this job to understand it. So, a common form of this question is someone will ask you, Lahiru, what do you know about the ANZCA training program?
Okay. And that would be something that hopefully you've looked at the 2013 curriculum, and basically what it is: introductory training, basic training, advanced training, a few of the hurdles to get through those, finally into fellowship. And I think if you just had a broad understanding of those hurdles and those expectations, maybe the volume of practice requirements, the workplace-based assessments, including the CXs, DOPS, and case-based discussions, yes. I feel like those are probably the things that come up time and time again in your training that take most of your time, I'd say. Yeah,
exactly. Yeah. And I think the exams as well.
Yeah,
I think the primary exams are a huge hurdle, and the interview panel know it's a huge hurdle, and it is in their interest to get candidates who they think are going to pass. And I think a pillar of that, more than your academic performance, is do you appreciate it's a difficult exam?
Yeah, that's right.
And then one of the questions I think you get asked is, I think one of the questions they've asked in the past is, the primary exam is very challenging. A lot of people fail it. How do you plan to get through this?
Absolutely.
I got asked, what do you think will be the challenge? What do you think is the main challenge of the anesthetic training program? And I said the exam, and I was not mistaken.
That's right. Yeah, we've all suffered, but you more recently. Congratulations on getting through that.
And so I think have a basic idea of the structure of the exam, what the format is. You don't need to know huge amounts of detail. Just show them that you care enough about this job to learn a little bit about it. Essentially, is what this comes down to.
And maybe a little bit about that. Like, what does it take to pass this exam? Broadly speaking, it's a long amount of study. I'd say up to 12 months of study, and this number that's bandied around is 1,000 hours of study. So when you divide that up into a year, or say 50 weeks, that's 20 hours a week. So that's say 2 hours every night, weeknight, and maybe 5 hours on each weekend day. And that's an incredible amount of work.
Yeah.
But just to think that 2 hours during the day, because you're immersing yourself in study during lists as well as afterwards, it is doable, but it is an incredible time requirement. And then other kind of peripheral things like making sure that you're registered for the exam, you sign up to it, you've got a study group, you've got all your resources, which includes having your having all the notes and the exam papers and a study plan. I think being able to talk to these points pretty fluidly, seamlessly would be a real benefit to you.
Yeah, and I think the best way to do it is chat to people who studied the exam. Everyone has, I guess, opinions about how to pass the exam, and I think they're all really valid. And I think just have a bit of a think about it. And I think if you show that you thought about it and you appreciate it's challenging, that's all you really need to know. And so I spoke a lot about kind of how to study techniques. As Larry knows, I got really deep into this in a really nerdy way about kind of the psychology of studying, and that's kind of how I prepared for it. And I generally looked at a lot of that before my interview. And I think that's kind of what they want.
Yeah, that's right. And most importantly, listen to the Anaesthesia Coffee Break podcast, because everything's in there. Completely joking. It's a shameless plug.
Jokes aside, you really should. It's a great podcast. Excellent. I think that's probably as much as we want to cover for college specific stuff.
Excellent. So just to recap, I guess what we've gone through is the clinical governance and how it relates to things like research, the audit cycle, education, and then the national standards. And there's 10 standards, and being able to potentially talk about them, what you've seen in hospital, as well as how you've implemented some of these standards. And I liked what you said about the three pillars of it, which was the audit, research, and education, that you probably already have a lot to do with. That's good. So moving on to the next question. This is probably a far more common question to get at a junior level, which is the more ethical questions. What would you do in certain situations that are prickly, that are very difficult to think about, and hopefully never happen in your career? And if they do rarely happen, it's very tough to deal with. So one of these is the impaired colleague. And when we were chatting about this before, I think Kaz had a really good mnemonic and a good way to structure this. So what do you reckon? If you get the question of, you're about to do a theatre list, and your consultant or one of the other registrars or someone, maybe the surgeon, seems to be impaired, seems to be under the influence, you smell alcohol in their breath or something of that nature, how do you approach this?
So there's a mnemonic that I can't take credit for. So which is PIES. So the principles of this are patient safety, investigate, escalate, and safety and support. And I guess three other things just to kind of keep in your mind is that what interviewers want from this is that you're non-judgmental, that you don't jump to conclusions, and that you behave in a professional way. So, accosting the person and, having a shouting match in the theater is probably not a professional or a empathic way to approach it. And, the college does a lot of work on kind of this sort of stuff. And the fundamental thing that they want to they try to get across is rehabilitation as opposed to repercussion. I can't remember that there's a word that they used, but essentially the goal is to rehabilitate people who are affected and get them back to work. It's not about actually punishing them or penalizing them. So I guess coming back to the question, so the main thing you want to do is make sure the patient's safe. So how is the patient safe to compromise? So well, if someone's drunk, inebriated, otherwise drug affected, their decision making and the quality of the care they can deliver is compromised. In another way, if someone goes, well, they're just stealing fentanyl or ketamine, how does that affect patient safety? Well, that patient's not getting adequate analgesia, so they're going to wake up in pain, and that's actually an element of patient safety. So ensure what you can to make sure the patient's safe, and that might mean that you give them more analgesia, if you're taking over the case, or you escalate to someone a bit earlier and make sure the patient's safe. And if someone's drunk and is unable to do their job properly, I think you need to escalate much, much quicker. And the second one is I, so investigate. So it's a key thing here that you want to find out as much as you can, as quickly as you can, as safely as you can. And another principle here is don't assume the worst. So assume the best. Assume that you might be wrong, that your information might be wrong. and it's about being professional in this aspect. So, how would you go about investigating a drug-affected colleague?
Yeah, so I think it's very tricky, and even at a junior level, this is again something that you probably need to escalate, because by investigating by yourself, I mean it's not your role. This is definitely above your pay grade, above your level of responsibility. And just to know that there's many ways that people in the right positions know how to do this. So I think it's almost a way of checking in that I feel like investigating is not necessarily your responsibility, but it is up to you to not be judgmental and be more concerned about patient safety and your colleagues' safety. So that really leads on to escalation. So just know that a lot of these things you'll hopefully never be ultimately responsible for, because there's people that are more senior and are trained in this. And, that includes the senior nurses, your consultant mentors, the director of the department, maybe the chief medical officer. And all of these people are far more capable of doing that. And in these junior roles, you'll never be asked to confront this on your own. Even in a senior role, you would never really confront this on your own. It'd be a team effort, because it's such a tricky area to navigate.
Yeah, I was going to say, I think most consultants wouldn't, intend to manage this by themselves. Everyone would escalate to the department head, whoever's on the floor, and then the appropriate executive with getting help. So you as a resident or a registrar, definitely not. You definitely lean on people around you.
That's right. Now, in terms of safety of the colleague and staff, I found that this was so important. There's a lot of things I didn't know, especially in the anesthetic context. There's a really high suicide risk, say if someone is found to be taking drugs and is confronted. So there's one of our documents, one of our welfare documents on the impaired colleague, or finding out that someone is at risk or has been confirmed as taking medications or illegal medications. There's a thing that says you cannot leave them alone. That's in the college documents, because if you were to leave them alone and they were just to go home by themselves, for example, they're at a very high suicide risk. So one of our one of those avenues of management really is to escalate to the duty psychiatrist, and potentially have that patient managed, have your colleague managed as an inpatient. This is such a tricky situation, so I don't expect anyone to know the detail of this, but to know that there's a high suicide risk and you have a feeling that this colleague shouldn't be left alone is probably some extra insight that would be important to know.
Exactly. And also some appreciation of the pathways to supporting them. So you don't need to know specifics, but I think knowing that you would have to support them personally in terms of addressing their issues and kind of supporting the rehabilitation and getting them safely back to work. You'd want to support them at a departmental level, so ensuring kind of the matter is handled in a professional way, and then supporting them at a college level, so finding ways to keep them get them back to work essentially. And if you wanted to really go for brownie points, you could then say support them on a societal level. So there's really other stuff about family and friends and the other non-work related personal stuff that I think are really challenging in confronting this sort of an issue. And I actually think there was a great article written by an anaesthetist in New Zealand. I think he was in Waikato, who was actually was diverting fentanyl for a large part of his career, and he's actually come out and spoken out about his experience. So when he was diverting, how his rehabilitation process, how he relapsed, how he then got rehabilitation. And he's actually written an article in the New Bulletin as well. So maybe we'll put a link in the show notes. I kind of recommend everyone read it. It's a pretty eye-opening and confronting piece. Have you come across it, Lars?
I haven't actually. And that's important to think about, because you're embarking upon a career that is pretty high risk in many ways for your own safety and health, let alone patient safety and health. And just to know that no one ever embarks upon a career thinking that it's going to happen to them. So just to be aware of that story, I can imagine would be very eye-opening and very useful. Okay, so that's pretty good. So essentially we've gone through the PIES approach, so patient safety, investigate, escalate, and then safety of the colleague and staff, and a few ways to do that. And then really we can, that's it. I was gonna say that hopefully this doesn't happen in your interview, but this can be made very, very difficult when the time frame between you're discovering the person is impaired and they're about to interact with a patient in a very serious manner, such as an anesthetic induction or full surgery, means that you have to escalate much quicker. So just imagine how uncomfortable that would be in real life, and why the escalation of this process might have to happen much sooner. So I think it can be quite easy if you just notice that your colleague is a bit impaired, but if they're about to do something, it's your absolute duty as a medical practitioner to put patient safety first. And in a junior role, I think escalation is the remedy for that.
Yeah, so that actually leads on really well to another concept, which is communication in a crisis and graded assertiveness. So if someone's about to do something, say, that is, puts a patient at danger or themselves at danger, there's the graded assertiveness mnemonic, which is PACE. So, you can probe, you can alert, you can challenge, and they call it emergency, but you can essentially escalate it quickly. So, it'd be pretty hard to apply this to this situation where someone's drug affected, but you could probe it by going, do you think maybe I should do the intubation? Alert, can we actually wait for someone else to get here? Challenge, please stop what you're doing while we get the in charge. Emergency, stop what you're doing. That's really challenging to apply to this. This is more in the realm of maybe someone about to do something, ignoring or not noticing a hypertensive patient on induction. You'd use the PACE mnemonic to address that, but you could also use it in this situation.
That's true.
If you're pushed to make a decision quickly in the interview.
But that's true. A lot of these are just frameworks that come up outside of the clinical sphere, really. And one of them is, what do you know about graded assertiveness? Once I hear those words, I think PACE approach, exactly how you said. I think that's pretty good. So then let's talk about a few other of these kind of ethical questions where, and these are probably a little less tense than the one we just discussed.
Yeah.
And one of them is colleague not pulling their weight, so not doing as much of the work as they should be. Maybe the trainees not coping with exams or stress. And then potentially patient ethics, so end-of-life discussions and family not wanting them to know about a diagnosis or something like that. So how do you apply this kind of framework to that?
Yeah, so I guess we'll start with the colleague not pulling their weight, or a perception of a colleague not pulling their weight. So common question, common scenario. I think everyone's been through this at some point. And I think it really speaks to a lot of the conflict in the workplace, that this is generally handled really poorly by everyone. So in the interview answer that you would give for this is patient safety. So again, if someone's not pulling their weight, are you compromising the care because you're now taking a bigger workload, or someone else is taking a bigger workload and not delivering the same quality of care? And then I also would put personal safety in there. So the person's safety. So, if they're not pulling their weight, you need to make sure that they're mentally and physically okay, that they're safe and they're being supported as well. So I would actually probably move that a bit earlier than the S in PIES. Investigate, try to find out more, ask them. And again, you can bring PACE into this. So you can investigate a number of ways. You generally should investigate in a non-accusatory and non-confrontational way. Just going, hey, I've noticed you've been late a few times. Like, how are you going? Is everything okay? It's just been a bit tough, like getting everything sorted when you've been late. And then you can escalate that to going, hey, like, I've noticed you've been late. It's being really hard. I'm actually finding the patients aren't getting the care they need. What can we do to make this better? And if that fails, then I think it's appropriate to escalate to escalate to your consultant, whoever's in charge, appropriate nursing staff, leadership, as well as directors. And then again, safety. We've already covered that, but your principal thing, I think what you want to get across in this is that they're okay. You want to get across that you're generally a kind of person who assumes the best in people, that you're not going to jump to conclusions that they're lazy or don't care about their job or want to actively harm people. You want to show that you're going to assume that they've got something going on. And I kind of just think that's just a generally good principle in life. Always assume the best in people, and you're often not wrong.
And I think you're right, because no one wakes up in the morning wanting to harm someone or perform poorly. There's other circumstances that are always going to be there that make someone not perform up to a standard. And I really like that. So, your basic assumption of everyone, I think we talk about this in sim all the time, which is you assume that everyone's capable, intelligent, and wants to do their best.
Yeah.
And that's a great way to lead into this, into these kind of discussions that, I think you're a great doctor, great, hardworking person. Are you okay? What's going on?
Yeah.
So how about and that's probably similar with the trainee not coping with the stress of exams. You can have a similar kind of discussion for that. But I think this one's potentially more tricky. So there's some rare situations that occur if someone, say, a patient who's elderly, potentially without much capacity, or if they do have capacity, they might have varying levels of consciousness, and maybe just really frail and elderly, like a fractured nerve patient who's, say, over 90 years of age with lots of comorbidities. And they may be palliative. They might need an end-of-life discussion, and the family may be part of that discussion, but not want them to know more of the details about that, or maybe a cancer diagnosis, for example. And that is really tricky. How do you deal with that?
Yeah, look, this is really hard, and I guess this is one of the few questions I don't have such a prescriptive way that I answer it. You could do the medical school kind of answer where you go through the 4 pillars of ethical practice, so beneficence, non-maleficence, justice, and autonomy, and they work really well, and you could use that for a phenomenal answer on this sort of a question. Alternatively, you can still use pies, so you can still go, well, the most important thing is the patient safe, and I would just give some consideration to the idea that patient safety can take a lot of different forms. Just what keeps the patient alive isn't necessarily the best thing or the safest thing for the patient, and there's a lot of emotional and spiritual aspects that come into it that are beyond are they physically well and alive, and I think showing that kind of shows a lot of maturity on your part, and Tulgawande is being mortal, I think, covers this in an exceptional way.
What was that? Sorry,
being mortal by Tulgawande. So he the entire book's essentially about mortality and what quality of life is, and a big chunk of the book is dedicated to end of life discussions and palliation and the care of the elderly and the aged.
I found that if there's any one author that you need to read before an interview, it's Tulgawande.
Yeah.
Whether it's patient safety and performance in terms of the Checklist Manifesto, or this current book, was it Being Mortal?
Being Mortal.
The interesting thing, as you're telling me how you approach these things, I just love that you have a framework. And again, this is one of the things we'll talk about in another session, that especially these days when interviews are over Zoom, you need to demonstrate that you have a framework, because it's very hard to get those visual cues when you're in person in a room with the other interviewers. And so just saying that, look, the framework I use for this is patient safety, investigate, and escalate, and then colleague safety. Once you've outlined your framework, you've listed those, the interviewer just knows what you're talking about. And, we can then, I guess, ask you to stop or, go on in more detail to certain aspects of it that we're interested in. But it shows a really great organization of your knowledge and your, whatever and your plan of action. I really like that. Whatever framework you use, I think highlighting it initially with a list and then going into the detail of it is probably a really good way for everything, whether it's these tricky situations, or why do you want to do anesthetics, or I give you a clinical scenario of a patient in pain. Having a list of the framework, identifying the framework before you go into the detail is really useful.
Exactly. And I think that's also really supported by the fact that that's how we answer vivas, and that's how we actually communicate clinically. So that's what some people do. Yeah. And I think this is kind of how particularly I think in anesthesia, and I think generally in medicine, we communicate in such an effective and concise way. And our exam answers, even if you do a viva or a long case, are often articulated that way. So I think we're actually primed to consume information that way. So while I just generally think it's a great way to communicate in interviews, I actually think it's supported by the fact that all these consultants have done a lot of exams and have a lot of experience being on the other side of assessing exams. That's how they're used to understand information. So if you can communicate that way, it kind of definitely helps your case. And I think good organization can make a mediocre answer great.
Absolutely. I think that's pretty good. So we've covered quite a bit there on the kind of the non-clinical aspects, some ethical questions, clinical governance type questions. Again, hopefully, is that all we need to cover today, Kaz?
I think so. I guess there's variations of this, but
Yeah.
If you have any specific questions you want us to cover, obviously give us an email and we have to discuss. But
yeah, if anyone's got any specific questions, some stuff that's really tripped them up, definitely we'll happy to give our opinions, and hopefully they're reasonable. So email us at anaesthesiapodcast@gmail.com. That's ANAESTHESIA podcast PODCAST @gmail.com. So I better spell this right. There's a whole bunch of A's and E's in there.
Great spelling there, though.
Thank you very much. So I guess we'll conclude that. So yeah, cue outro music, and thank you very much everyone for watching and listening. Again, if you think if you think this is useful, find this useful, please share with anyone who might be, especially now that we're coming up to applications. And for the next episode, we'll go through clinical questions and also the lateral thinking questions, which always can be really easy to trip up on, especially because the clinical questions could be incredibly hard and incredibly detailed. So that's all from us for now. I'm Lahiru.
And I'm Kaz, and we'll see you next time.